Welcome to the Australian Institute of Health Innovation Seminar. I'm Joanna Westbrook, and it is a great pleasure to introduce Professor Enrico Coiera today. He really doesn't require any introduction to this group, but nonetheless, many of you will know that Enrico is a leading national and international researcher in health informatics. He's written the Bible on health informatics, which if you haven't read it, you really must. It's a fantastic detailed, textbook on health informatics, but it's incredibly readable as well, which is a great benefit. So it's really worth reading. It's cheap as well. Okay, it's cheap as well. Enrico's has been running as we know, the longest health informatics research centre in Australia. I mean, he's made an enormous contribution to all sorts of areas of research, but one of the areas he's probably most renowned for is his really insightful, pithy pieces that appear in the BMJ or some of these leading journals about new ideas in health informatics. And he's often, one step ahead of the curve in those areas. And many of you will know these pieces, which, are really very highly cited and have, shifted the direction of health informatics in many different ways. So it is a really great pleasure to have him speak today on, I'm sure, another really bright idea. Enrico.
So nothing to live up to then. So normally, I'm the one doing the introductions, and it's your hardest job is to think of the hard question at the end if nobody asks a question. So you're off the hook. Joe, you don't have to do that. What I thought I would do today is so today is an ideas talk, and so I apologise for that. And to let you almost into my head a bit, and again I apologise for that. This is sort of the way I understand informatics works and why things don't always go the way we'd like them to go. And what I'd like to give you are two models through the talk, and I hope they make sense, that might maybe help you think about things as you progress. So this is sort of the lay of the land in informatics, I think. Up here is the Shire Standards, which is a beautiful, green, quiet place. Everything is in order. There's a place for every standard, and every standard has its place. We build beautiful systems that work, and it's just a lovely digital nirvana. What happens, though, is occasionally one or two of the folks in the Shire go and cross this thing called the river of implementation into the rest of the world. And then things start to change. You might be stuck in the rocky workaround mountains. So these are the places where people will take the tools you've built and go out of their way not to use them in the way you designed them. You might get stuck in the human factors marshes, which is where people will use your system exactly the way you designed it and cause trouble. And if you're very unlucky, you'll end up in this dark place called Mordor in the view of the giant public eye, right? And you don't want to be down there when things are going wrong. So why is that journey often so difficult? And are there other journeys, are there other maps, is my question for the day. And so I thought, given that, as Joe has pointed out, I'm now very old, I would go back to a couple of things I've said in the past, just as signposts. So this is something I said when I was quite young. Kind of a bold statement that informatics is as much about computers as cardiology is about stethoscopes. The idea that the technology is not the point of why we're here. And also, any attempt to use technology will fail if our motivation is the technology and not solving problems. I think the thing I would change today is change the word any, because that was pretty absolute. When you're young, everything's absolute, to say almost always. The next thing, though, is to say that that's not necessarily new thinking. This is Chuck Friedman's fundamental theorem of informatics, and Chuck is another great thinker from the US. And this is not a statement of what will happen. This is a statement of saying informatics is going well when people plus computers are better than people unaided. It's a statement of intent, and people often misunderstand it. So both those things really are around saying something about technology needs to make us do things that are better than otherwise they would be. But I want to contrast that with something else I wrote quite a long time ago too, which is to reflect that technology doesn't really always cover everything that we do. So here I talked about something called the communication space, which which I asserted then, I think is right, is the biggest part of what we do. Most of what happens in terms of information in the health system is between people still. It's where we talk to each other, where we make sense of the world and we interact. The electronic record doesn't mediate all of that. And so where does that fit in the world of Chuck Friedman's theorem? That's almost ignored, isn't it? So those are the two worlds I'd like to try and reconcile today. So let's go on a journey. The first thing I'd like to talk about is this notion that information is going to make things better. Adding information to the bucket of healthcare is going to make healthcare better, right? A little drop of information is going to make all our processes better than before. And I guess if a little information is good, then a whole lot's got to be better, correct? Just by definition. So, Joe mentioned the textbook, and I've summarised the textbook for you in one slide. But it's really worth the journey of buying it, really. So this is really a summary of all the meta-analyses and systematic reviews across all the major health informatics intervention classes. And it's worth spending time to understand what they say. Electronic health records decrease nurse time, but increase doctor documentation time. So whenever you look at it, docs spend more time documenting than before. Records are more complete, but we can't typically demonstrate any effect on quality and safety. Repeatedly, doesn't happen. Automated care pathways and plans, very good at the reduced practice variation, and we don't like variation typically. We find increased compliance with standards, and we can see improvements in process behaviours, so test ordering more in line with standard, or drugs ordered more appropriately. But again, typically no impact on clinical outcomes, length of stay, death. Typically, you will find some papers, but overall that's what all the systematic reviews say. And we have to kind of take it at face value. Let's look at telehealth now. Telehealth makes patients happier. In some cases, there are improvements in outcomes in chronic care, for example, chronic heart failure, etc. It's surprisingly not cost effective. In fact, there was a paper just in Health Affairs yesterday that made the same surprising result that we've now known for a while, that telecare doesn't necessarily improve cost effectiveness. And then lost at the bottom here, this little thing called decision support, which we never talk about much, is the only class of intervention that always improves outcomes, always improves safety and efficiency when tested in the meta-analyses. It's interesting though when you reflect on where all our effort goes in e-health, where we're investing. It's interesting. Okay, so faced with that conundrum, how do we start to bring order to that and make sense of it? Is this bad, or is in fact what we would expect? And so an idea that I like is this notion of the value of information. So if you do clinical research, you know this idea of the number needed to treat. How many patients must I give my red pill to before one patient gets better? Number needed to treat. There's another idea which is similar, which is the number needed to read. How many times must somebody read this document before something changes? If it's a guideline or an electronic record, how many times does this guideline have to be read before something changes in the world? There's a thought. And so this led me to kind of try and unpack it. And so this is a very simple deconstruction of what happens when we use an information system. So we turn it on, we interact with it. If, say it's a medical record, we might receive some information. Sometimes that information changes what we do. Patient's allergic, I'm not going to prescribe that drug. Hopefully those decisions result in some change in what happens in care, but that doesn't always happen. I might order a drug and it may never get administered. And then at the very end there, something might change in terms of outcomes. So there's a pipeline and there's a loss as you go down that pipeline. And And so the value of information is very different at each stage. So, you know, reading an electronic record sort of happens here, but it's unlikely to be as important as the information that tells you to change a care process. The other thing to note is that it's busier over here on the left, isn't it? Many events, many times I interact with that record, very few events where outcomes are changed. But equally, the further you go down that chain, each event is much more valuable. Just to give you an idea, so here is some work by Wouter Good. He was actually a visitor here at the beginning of the year, who took that model and he tried to see if it would help them understand how they were going with a decision support system. And the point of this decision support system was to help clinicians understand whether their practice was in line with the recommendations for cardiac rehab. And he broke it down into those steps. You know, you log into the system, the decision support system gives you some information about how well you're doing compared to others. You work with the system to agree a plan on the things you're going to change in your clinical behaviour. We then go and measure the changes, and then there might be some outcome change. And Wouter's question was, why did this system have no impact whatsoever on clinical outcomes? And so he took the value chain and he just deconstructed it. I'm sorry for the formatting challenges there, but you can see just in terms of frequency, you know, 50 feedback sessions, lots of information about where people were not meeting their indicators. Clinicians agreed to change their behaviour in nearly 380 times. They only actually did it in 31 cases. And surprise, surprise, no change in outcomes. So where is the problem? It's probably not here in the decision support system, but it's something here in terms of integration with workflow and compliance. So this chain gives you at least an indicator of where things are going well or not going so well. Now, from my point of view, that's great, but not really that useful because there's still no value attached. That's just a set of frequencies. You know, those 31 actions that were completed might have actually been really important. So it's important to not look at frequency, but this idea of the true value of information. And so this is my only technical bit, and it's easy, really go with me. So this is what the technical definition of the value of information. So you've got a decision, a patient's got a symptom, and I want now to do a test to see what's wrong with them. I've got two tests, and which one is the one I should use? And so what you do is you calculate in decision theory what's called the utility or expected utility, which is two things. It's how likely is it that I'm going to succeed in finding that thing, or how likely is that event, and how valuable is it should it occur. To give you an example, if you're a climate change skeptic and you say, look, the likelihood of climate change happening is really quite small. Decision theory would say, okay, that's a very small p. How big is the value of getting this wrong? And it's kind of, well, you're betting the planet. So even if you're a skeptic, decision theory says you better do something because the price is pretty high. Yeah? So that's all it is. It's very simple. And so you calculate your expected utility or value for both of those possible tests. Yeah? And so technically the value of information is this. It's just the difference between the two tests. So how much value was there in doing the chest x-ray versus doing the blood test? Well, I might have found 10 more people, and that has a real value in the real world because I can do something about it. So there's your technical value of information. This is as hard as it's going to get. So that then allows me to give you your first model. And what I've done here is I've taken the chain and I've put it down the bottom here. These are just steps in a process. And then I'm just saying, let's measure the value of the system at any one time. And just to keep things easy, I've said, this is just the world as it is without the computer in the way. And so the first thing it does is give us a way of plotting those things I started with. So that's Chuck Friedman's fundamental theorem up there. That's using computers to make things better. And that's my old communication space down here. That's where technology doesn't really help us so much. We're doing what we do anyway. So what I can do now is for each of those 5 things that I talked about, records, etc., plot them here. So let's plot the electronic record. So we know the electronic record is a pain to use. You know, doctors spend more time, there's a disutility in engagement with the record. We also know, and I'm being generous here, that there's probably very little benefit in terms of outcomes down there. I've given it some because it's just got to make a difference, but it's very hard to measure. Let's look at some of the other interventions. Care pathways, they really, they make things easy to use because they reduce interaction. Things are all in bundles for you. You have order sets, etc. And the big value is here in process changes, not so much here. But that's still great because process changes might save dollars. So you might use them for a very different reason. Teleconsultation. You know, I always get surprised when people say telemedicine makes no difference in terms of outcomes. Well, it's meant to be a replacement for a face-to-face, not an improvement. So its job is to reduce, you know, the cost of accessing somebody, reducing travel time. You can probably access people in the evening when they're not otherwise available. So its benefits all come here around access to care. And that's not a negative. That's exactly what you'd expect. Decision support. Traditionally, anyway, decision support really wasn't popular because there's a real disutility or a cost to using it. You know, if I've got to answer questions from the computer, the patient has X, the patient has Y. But what's happened over the last few years is that we're finding ways of embedding decision support so that it doesn't really cost so much. And it really has huge benefits, as I said, down the track. So I'd like to think that when we look at technology and whether it makes a difference or not, we should be thinking about where the benefits and the costs are and asking appropriate questions. I would argue that anybody who tries to demonstrate the impact on outcomes of the electronic record doesn't understand the question they're asking because it's so far away from outcome. Why would it make a difference? It's an enabling technology. Yeah, it's other things need to work with it. So let's just summarise then. So information only has value when it changes what we do for the better, right? There's got to be that number needed to read. It's got to do something. Lots of information in a giant bucket achieves nothing. I think those value signatures work for me, and other people seem to like them too, as a way of understanding the nature of different interventions. The electronic record, as I've said, is just too upstream from decision making to easily see changes. And so we should better see, I think, you know, e-health as solutions bundled on top of the record, etc. And just my old bugbear that we really need to be talking actively about decision support technology, which is just lost endlessly in the discussions around digital health equals electronic record. Okay. Was that all right? So the next thing I want to talk about is this idea that human work can somehow be replaced by the computer. The assumption that the things that we do are automatable. Although I've got to say it's increasingly the case that things we thought were not are. Clearly news now can be written by bots. Certainly Breitbart is a bot. So there's this notion that, you know, work is linear and you can just turn a piece of it into a machine, and that's what the Friedman theorem says, you know. The thing that we've noticed, isn't it, though, that when you do that, is that people rebel, don't we? We rebel. We work around it. We don't like that piece of machine, or it doesn't quite do what we want to do, so we do other things there. And that, I would argue, is really enabled by the tools that I would place in the communication space. Talk, paper, all sorts of other things that people have. Sticky tape on walls. You probably have seen this one, but I just love it. It says, you know, this is where the idea for the new record starts to get a little complicated. We've seen that one before, I love it. And so, as Jeffrey would say, you know, that area is work as imagined, right? And there's the work as done. So things get messy once you start to try and map things to actually what really happens when you leave the Shire and you go into the world of workarounds. So, and just to give you an idea, here are some photographs I took a few years ago with Mei Sing Ong. of a New South Wales hospital with a Cerner system, which I hope has been updated since then, and just to point out what we mean by workarounds. So there's the lovely, very expensive Cerner system. There's someone who's stuck on the wall. Well, what do all the icons mean? Because the icons have no, they don't mean anything. You know, an icon is meant to represent something, obviously and easily, but clearly the designers there didn't really care much about that. Look at this one. You know, protect your security. Don't forget to log off. What design failure is that? That it's so easy to walk away from a system and leave it live and let somebody else log on as you. That is kind of a telling failure of system design. Oh, and just in case, here's the manual. All right, so what I like to say is just walk around your GP's office. Just walk around any ward or any other place you go and look for the bits of paper. Because the bits of paper tell you where work is imagined and work is done don't match. So why does this happen? Number one, simply because designers often confuse the work they imagine we do or the work we tell them that we do, which is still what we imagine actually happens, with actually what really happens. And streamlining things is great, but often there are variations that happen locally that are there for a reason. And by cutting them off, you do things that you may not anticipate. Designs always assume that the computer has your full attention. I'm sitting there tapping away at my Cerner system, except in the hospital, I'm being interrupted. My beeper's going off. A colleague is talking to me. I'm worrying about the patient I was asked to see down in emergency. I'm cognitively loaded and doing lots of other things. That machine does not have my attention. The other thing is, in reality, work just is not linear. It's not a set of predictable steps. And there are often dependencies that we don't anticipate. A good colleague of ours, Marie Biscout, looked at the use of electronic prescribing and was looking at what happened when you move prescribing from the bedside to giving a prescribing station, which was in the ward area where all the records were. And she noticed that by moving the electronic prescribing from the bedside to somewhere remote, you lost something that people didn't think about, which was that at the bedside, the clinicians, the doctors and nurses, would discuss the patient and the data at the same time. They would discuss what's going on in or around whatever. By decoupling prescription from being present with the patient, you lost an important part of the process that was never imagined at the time. Okay, so one of my messages is that workarounds are gifts to us because they signal there's a mismatch between what we think we're doing and what people really need. So workarounds are repairs to our faulty designs. They suggest information that's missing, that should be there. They suggest new pathways or tools that we haven't imagined. And they are ways of making us understand that work is shifting. So, you know, you can design a system for 2017, come 2019, patients have changed, work has changed, treatments have changed, and the system hasn't kept up. And what people do often is they'll resort to communication tools, you know, email, chats, bits of paper stuck to the wall to circumnavigate what's happening. So I do remember, you know, early on when I was working at the IT department back in 1850 at Royal North Shore Hospital, I thought, you know, what is all this stuff on the walls? And can't we just take it off? It's an affront to my need to have everything clean and organised. It turns out that my office is not as good as Jeffrey's office, because Jeffrey's office is full of workarounds everywhere. So this leads us to really the final part of the talk and trying to bring those ideas together. This is not a small question. Which tasks should we automate? We never really ask that question. We just presume that there's work out there and the technology can come in and make things better. We never actually say, no, that's not really a good object for automation. We just dive in. And then we succeeded, we fail, without that reflection. So there have to be, by definition, the sorts of processes where technology is the winner, and the real rate-limiting step is the human. Obviously, the things where computers are pretty good at, which we're not so good at. But equally, there are a whole bunch of things where technology is not king. We are, in fact, the ones who are much better at it, and technology is the bottleneck for getting things done. So how do we try and put those different worlds into some sort of model? And so this is the model I proposed, my second model. So I talked a lot about expected utility, and I talked before about trying to measure the utility of a technology. And so that's this line here. And I'm saying, well, also just imagine for any given task, there's a utility for a human doing it. In other words, how well does the computer do it versus how well does the person do it? And let's just plot those out. So the first thing you can notice is that there's obviously a line, and everything above the line is where computers are better than humans, and everything below the line is where humans triumph. So let's now just go through each of those spaces, because this then is the geography I want you to think about. So what's happening here? Computers are fantastic, people are suboptimal. This is, calculating pi to 5,000 places in a second. We're just not going to do that. Auto trading on the stock market, we're just not going to do that. Interpreting complex 3D images, computers are better at that. So there have to be a whole bunch of things where rationally it makes sense that we automate. Down here is a really bad place. This is where neither humans or computers are good at things. And right down the bottom here, where people are very bad and computers are bad, I call it the dead zone. That's probably Mordor, isn't it? There must be tasks in that place, and there's not much we can do at the moment. And we can slightly improve our performance in what I call this mitigation zone. This bit here, bottom right, where people are great, technology is poor, is really what I was always talking about when we talk about the communication space. That's where we win. And what do we have left? What we have left is what I would call a joint workspace. This is where humans and technology can both add value. Above the line is the beautiful world of Chuck Friedman. This is where the computers make us much better than we'll be on our own. And down the bottom is the world where we know more. This is where workarounds happen, right? So technology is an aid, but it's just we're a bit smarter. And so really, it would be great to know before you started what you're doing, where you were going and where your task set fits, because that really dictates how you choose to approach it. And just to kind of now bring the two models together. So I had those signatures for you, the signatures for electronic records, and this is sort of the space of where things go well to don't go so well. So what I would love to see, in say in the next edition, which I'll write in 15 or 20,000 years' time, is to see this sort of a diagram where we can say, for a given technology, how well is it doing? Where does it fit in the space? Clearly, right now, there are some real deficits and we need to change them. We should be able to predict, or if not predict, at least then measure after the fact to make really informed decisions. And I think with that perspective, you really change the way you approach the evaluation of technology and you change the approach of design. At least I hope I do. Anyway, I think that's enough of being inside my head. And I'll just say, if you know where you are, then you've got a better chance of knowing where to go. So the idea of the compass is what I was hoping to get to you. Thank you very much. That's exactly what I'm saying, that workarounds are clues to designers about mismatch. It doesn't have to. A workaround might say, today we do it this way, stop doing that old bit, swap modules. So it might simply indicate a change in work. Another approach is to say there will always be a piece of work that needs to be locally adapted. So let's give you the tools to do that. Let's embed a bit of local adaptability into the system. So if you today go to any hospital and say, I'd like to change this box to here, you can't do that as a user. You've got to negotiate a change request through the IT department, who will put it onto a list of 5,000 priorities, and it's unlikely to happen. So I think accreting changes without understanding that they're adding to complexity is a bad thing. So you have to actively manage complexity growth. I completely agree. So I didn't say they're not useful. I said it's hard to measure impact on outcomes. That's a different thing. So the way I see it is that they are core infrastructure. So it's like having roads. You have to have them. However, you wouldn't say you've got a transport system if you'd only built roads. So we've got to add the other stuff on top. So IBM Watson is sort of set it aside because as academics we actually don't know what's inside the box, and we've rarely seen evaluations. So at least some of us are sceptical. It might be more marketing than reality. But if the question is, are we moving to a place where there's more decision support? There's a lot of interest in it now, which is fantastic. But those technologies have been available since the mid-80s, so 30 or more years, and were not adopted then. So the things that have been well adopted are things that hide behind the scenes. So, path reports all are screened computationally. ECGs can be read automatically. Radiologists will have systems helping them look for lesions. So anything that is, you might get alert prompts and reminders which don't require you to put information in but respond to what you do. Those are the sorts of things we've seen, and they probably reflect the fact that people are unwilling to give information in return for support. So I think half of the anxiety I've got is that there's a lot of excitement now around decision support, machine learning. People talk about AI, but they're not. They're just talking about algorithms. They certainly can perform well, but they've always performed well. The issue really is how does that fit with work? And that hasn't changed. So I think we're on the same page actually. So what I would say is there was a thing called the large-scale demonstrator in the UK for telehealth, which essentially killed a lot of telehealth in NHS because they said based on narrow judgments there were no improvement in outcomes and it was more expensive. But they didn't factor in a lot of the things that you spoke about, which are the unmeasured benefits. And so I think, my view is it's actually an unfair thing to criticise a record because you don't see outcome changes, because that's not its point. And I would say it's unfair to criticise telehealth because, again, it might be more expensive. I mean, so if you go to that Health Affairs paper which came out yesterday, they don't cost, downstream benefits at all. They don't cost, the person with an obscure infarct that's happening now and they send straight to emergency, which would have cost us hundreds of thousands had that been missed. So I think, we are limited by what people measure. Look, I think yes, but going back to the idea of number needed to read, so there are two ideas. One is, can you make the AIHI easier to use? I think the answer might be yes. And can you increase the likelihood that if there is relevant information, it gets seen and acted on? Yes, you can do that. But still the point is, how many times do I read the record before I actually change something? Because most of the record is very routine. And so it's just simply a question of numbers. So I think when all people do is say, look, when they do the evaluations, the records are placed in the system, and then they look at benefits on process at the end in terms of length of stay, death, etc. I think they presume that the input-output is going on. They're not measuring it at that micro level. You'd have to do a study, which would be great for a PhD. Although in that paper they didn't measure outcomes in the end. So they didn't even go to the end of the chain. So I would say, well, that's a premature assessment. You can't really say much at all. Yes, it costed more, but maybe that was well worth that cost. It's the same argument for having GPs. People say, people, wasting their time seeing their GP. Well, for every early tumour detected, think of how much money and suffering is saved. So, so primary care is a great example of huge cost benefit. So I think second part first, I think that the value chain is a very simple idea restated, I think. It's just a simple model, but it's almost a checklist for looking at literature, evaluating what you read, or guiding your own thoughts about the way you approach, the decision to intervene. As I said, it's actually a decision to intervene and to build something. We shouldn't just assume we're going to do it. So I think it seems like a useful framework. We've used it a few times now for some of our work in our own centre, and it does really, what it often does is show huge gaps in the literature. Okay, people have actually only measured these two bits and they've all forgotten this chunk here in the middle. In terms of growing complexity, I've got some views around complexity. It needs to be actively managed, that we just don't add stuff in without deleting. And I think there was a question early on about, how variation adds to complexity. So we're not very mature at developing ways of allowing people to vary practice appropriately in a controlled way. So we have the universe of everybody has the variations that they want, or here's the standard you should comply with. What we don't have is the adaptive piece in the middle, which says here's the piece we all agree probably we all should do. If you could then now adapt around that according to the following well-behaved rules, I think we have a chance of controlling it. It's a beautiful point, and you remind me of that classic book by Don Norman called The Psychology of Everyday Things, or Design of Everyday Things, and he talks about the handle on a door, and he says it should be obvious when you get to a door if you should pull or push based on the handle. So the design should tell you what happens next. And if you think about that lovely Cerner system I showed up, how much information did you need to have to use that system? The design didn't tell you what had to happen next. So if you look at Apple products, how beautiful are they? And you compare the money invested in design there for that commodity product with the stuff that we have to use clinically. So there's a real lack of value on good design. And I think there must be something about the healthcare marketplace that makes it so. So part of the answer, I think, is that we don't value beautiful, clean, simple design. The other part is that we all want to do things differently, which goes back to Jeffrey's question. And I think you just have to say, look, practice is indeed this is not a Toyota factory. There are differences, but let's manage those differences in a way that at least is well behaved, I don't know if that's an answer, but...
Well, I think it's very, very clear. I'm sure everyone will agree that you delivered on the promise of presenting some really interesting ideas in a really excellent talk. So thank you very much.
Thanks, Joe.
You don't get it back.
Thank God.